everyone, it's Dr. Clark and Iris. We're going to demonstrate the abdominal exam for you today. And so I'm starting out examining the patient from her right side. I have her draped, and then I'll make adjustments after I have her laid back. And I'll also make sure that I pull out the footrest. So would you mind laying down for me, please? Okay, and do you feel comfortable like that?
Yes.
And so as I get started, I'm going to ask you to lift your shirt up just a little bit for me. Do you mind doing that?
No, I do not.
That is perfect. And so as I start out with the abdominal exam, initially I'm inspecting for any areas of asymmetry. I'm inspecting for the contour. I'm looking at the patient's umbilicus. I'm looking for any signs of inflammation or any sort of pathology. And I don't appreciate that. Are you having any pain anywhere today?
No.
Okay, and so the patient's not having any pain. If the patient were having abdominal pain, I'd make note of that and carefully proceed with my exam, making sure to examine any painful areas last. I'm going to start out just listening in all four quadrants of the abdomen in a clockwise fashion, listening with the diaphragm of my stethoscope for bowel sounds. Listen in each area. Typically after a few seconds you'll be able to hear bowel sounds. If you can't, you need to make sure that you're listening for a longer period of time to determine what's happening with the patient, whether they have, for example, an ileus or some other sort of pathology that's happening. At this point, I'm going to use the bell of my stethoscope to listen for. Now I'm going to move on to listening over arterial areas for bruit. So I want to first listen over the aorta. Listening for aortic bruits. I'll listen over the renal arteries for renal bruits, again with the bell of my stethoscope. I want to listen for iliac bruits. I need to adjust this a little bit. I'm listening for iliac bruits. I don't know if it's on the camera or not. Well, listen here for iliac bruits. Iliac bruits on the other side. And then lastly, I'm going to listen with the bell of my stethoscope over the liver edge for friction rubs. And then over the spleen for friction rubs as well. Now I'm going to move on to light palpation. So first I'm going to palpate in all four quadrants, looking at the patient's face for any signs of discomfort or pain. And then I'll move on to deep palpation, essentially laying one hand over the other. And again, palpating in a clockwise fashion, looking for any signs of pain on the part of the patient, but also feeling for any areas of asymmetry or anything that would be concerning in the underlying tissues. Lastly, I'm going to palpate the aorta, which lies on, slightly to the left of the midline. And I find it helpful to use slightly deep palpation with one hand, and then with the other hand come on the other side. Until you feel the edge of the aorta pulsing against both hands. So now I'm going to move on to examining the liver, spleen, and kidneys, and I'll start out by percussing the patient's abdomen, listening for changes in the percussion tone from tympany to dullness, and then alternatively percussing from the patient's thorax down, listening for a change in percussion tone from resonant to dullness which then allows me to estimate the liver span. Normally, that is going to be between 6 and 12 centimeters if you're percussing in the mid-clavicular line. I'm just going to tap on your belly. I hear dullness right about here. I'm then going to percuss downward until I hear dullness again. Change from dullness, or from resonant to dullness, and that would constitute the liver span. Next, I'm going to move on to percuss the spleen. I'm going to start in the patient's anterior axillary line and percuss over towards the mid-axillary line, listening for any change from tympany to dullness. After that, I'm going to stay in that same place and continue to percuss, but ask the patient to inhale, which should drop the spleen down, and if it were enlarged, potentially you would hear a change in percussion note as well. Okay, so I'm just going to tap again. You can continue to breathe normally. Okay, you mind taking a deep breath in? And now I'm percussing in the same area, noting any change in percussion tone, and I don't appreciate any. Next, I'm going to move on to palpation of the liver and the spleen, so you can breathe normally. For palpation of the liver, I'm going to use one of my hands, use my dominant hand or my right hand for palpation, and use my left hand to support the patient's the patient's back, and sort of bring the liver towards my hand, or bring the tissues up to me. And then push down and have the patient breathe in and out, essentially trying to appreciate if I can feel the edge of the liver, which is going to be the normal finding for most people. So certainly you'd be able to ascertain if the patient's liver is enlarged by comparing what's normal to what you might feel in an abnormal instance. Okay, so I'm just going to push down. You can breathe normally, and then just breathe in and out for me. Okay, good. Now I'm going to move on to palpating the patient's spleen. Now I'm going to move on to palpate the patient's spleen, and so for this I'm going to reach across the patient's abdomen, use my left hand to support her back or bring the tissues closer to me, and again push down under the left costal margin with my examining hand. Have the patient breathe in and out, noting any differences in what I feel with inhalation and exhalation. So just breathe in and out for me. Good. And in doing so, I don't feel any difference. I'm unable to palpate her spleen, which means that it likely is not enlarged. Next, I'm going to move on to palpating or attempting to capture the kidneys. In most patients, you won't be able to do this, but you can attempt to, again, support the patient's back or spine. You're a little lower than you would have been for palpating the kidney, or you're a little lower than you would have been for palpating the liver and the spleen. I'm going to pull her back towards me, up towards me, push down over her abdomen. Remember, the kidneys are retroperitoneal, and for the most part, you won't be able to feel them unless they're significantly enlarged. I'll do the same thing on the other side, so lifting towards me, applying a little bit of pressure, and again trying to capture the patient's kidneys, or kidney on this side, which I am unable to do. And then next I'm going to ask you, do you mind sitting up for me? I'm going to assess for costovertebral angle tenderness, or CVA tenderness. And then with the patient seated and facing away from me, I'm going to place one of my hands on the anatomic area overlying the kidneys and make a fist and gently tap against my hand. And do the same thing on the other side, asking the patient if she's feeling any pain. Was that uncomfortable or did that hurt you at all?
No.
All right. Next, I'm going to move on to our specialized test. I'm going to ask you to lie back down for me. Next, I'm going to move on to the test for ascites and for appendicitis. So I'm going to ask the patient to place her hands midline over her abdomen. I will initiate a stimulus of tapping on one side of her abdomen, looking for a resultant fluid wave on the other side. And so I'm going to tap on one side, and then I'm feeling for transmission of that energy with my other hand. Do best to do it this way. So I'm just tapping, and I don't appreciate any transmission of that fluid wave. Okay, you can put your hands down. The other exam that I'll demonstrate is the test for shifting dullness. So this would be in a patient who I suspected had ascites. I'm going to start by percussing from an area of tympany down to dullness, which typically is going to be at the patient's flanks. And then what I'll ask you to do is, can you roll over on your side towards me? Have the patient roll over into a lateral decubitus position, and now I'm percussing from the lateral aspect down with the expectation that the area of dullness has shifted. Now her left side will have a tympanic percussion note, and because the fluid has shifted, I should percuss, or should hear a dull percussion note over most of the abdomen. I'm now going to perform the Murphy sign for cholecystitis. Oftentimes people combine this with palpation of the liver. What I'm going to do is use my right hand, my examining hand, place it underneath the right costal margin. Ask the patient to inhale, which is going to drop the liver edge and the gallbladder down, and I'm going to continue to apply some pressure. And a positive Murphy sign is cessation of inhalation. So if she suddenly stopped breathing, that would be a positive Murphy sign. And then lastly, I'm going to walk through the 4 tests for appendicitis. So the first is going to be palpating over McBurney's point, which is about 2/3 the distance between the umbilicus and the ASIS. So I could palpate here and assess for point tenderness. Does that hurt you at all?
Not at all.
Next, I'm going to perform the Robsing sign, which is a rebound tenderness test. And so I'm going to palpate, I'm looking for any pain or tenderness when I release my hand. So I'm going to push here. Did that hurt at all? Did it hurt when I let my hand go?
No.
I'm going to do the operator test, have her bring her right knee, and then essentially I'm just going to move your knee this way and moving your foot outward. Does that make anything hurt? Extend your leg out, and can you raise your leg against my hand? And I'm going to push against. Does that hurt anything?
No.
Okay. Alrighty, so you've got a negative psoas test. So that concludes our abdominal exam.